Welcome to the webinar Plan Success, Digital Tools for Full Arch Provisionalization. The lecture is being presented, I should say co-presented, by Wayne Cesara, CDT, and Tremaine Watkins, CDT, and we're going to begin shortly. And it is my pleasure to turn the course over to our wonderful guest speakers this evening. Take it away, gentlemen.
All right. Well, sounds good. Well, Tremaine, I'm gonna start out if you don't mind. And
Absolutely.
Jessica, yeah, I'm sorry. What'd you say?
I said, absolutely, go for it.
Sounds like a good plan. You know, it's live programs together are wonderful, but you know the webinars. I'm in Chicago, and Tremaine, I know you'll let people know where you're at. But here we are working together, working through the computer screen. But I'm really excited. And Jessica, I want to thank you. I want to thank NDX National Dentex Labs for the opportunity to talk to you all tonight. And you know, when I talked to Jessica and I was talking with Tremaine, we were trying to figure out some ideas and thoughts in regards to a very educational program, but something that will help you all on a day-to-day basis. So welcome. And so I'm going to go ahead and I'm going to begin my slide presentation. The title that we have for tonight is Plan Success, Digital Tools for Full Arch Provisionalization. So the first thing here through NDX, commercial support disclosure. So this is commercial support, and this is basically a disclosure that we have to show you to begin our presentation. I'm going to pass it over to Tremaine. So why don't you go ahead and tell us about who you are, Tremaine, and what you do for us.
Hi, everybody. This is, I'm in Albuquerque, so the view of my background, this isn't a stock background, this is a picture my wife took from our backyard. So that in Albuquerque, we live near the Sandia Mountains, and that's what they look like. I'm the Director of Strategic Education for National Dentex. I've been in the dental lab field for more than 35 years. Obviously, starting 35 years ago, I started in the analog world. I just don't like it too much anymore. So I really focus on digital. That's my favorite. And I'll be talking about digital workflows tonight. I've provided quite a bit of support for clinicians, both in the office and through training. And I do a lot of training for dental technicians. I think I've trained people in everything but orthodontics. That's always been kind of my Achilles heel. And I'm looking forward to talking to you tonight. Wayne and I were talking before the course, and our hope for you guys tonight is that when you're finished with the course, we believe we'll have covered every avenue for provisionalization for All-on-X, which you guys know is probably the most stressful part of the process. So that way you can kind of pick one or two that, well, all four if you want, I guess, but usually one or two that fit best with your practice and your patients. On the next slide, we also need to disclose how we're paid for this, and I am a full-time employee of National Dentex. So Wayne, it's all you.
All right, sounds good. Thanks, Tremaine. And for myself, being co-presenter, my name is Wayne Zara. I'm a clinical education manager with Zimvi Dental. So that's the company that I work for. And I'm proud to tell you a 32-year CDT within the organization. I have 36 years plus of experience working with implants and prosthetics. And I'm very proud to tell you that I'm celebrating almost 23 years. It'll be 23 years next month working for Zimvi. When we started with the organization, when I began, there was about 40 reps for the company, and it was called 3i, Implant Innovations. And then it was Biomet 3i, and then Zimmer Biomet, and our current company name that I work for is Zimvi Dental. And what I do as a clinical education manager is I lecture and travel in the field. I cover North America, and I present courses. And I present courses on all different subjects of implants and prosthetics. But I will tell you, my love is really the full arch. I mean, I love all aspects of implant dentistry, but when it comes down to full arch and changing a patient's life, you know, in regards to their lives and changing and just creating smiles and all the wonderful advantages to that is something I'm proud to tell you that I've been involved with for over 22 years. So that's what I do. I cover, we have about 180 reps in the field. and I travel and I lecture and I teach, and I love everything that I do. And I'm really looking forward to presenting to you guys all tonight. This is my disclosure. I'm an employee of full time with Zimvi Dental. So that's the organization that I work for. So tonight we have a variety of different learning objectives. Number one, identify the digital records and data acquisition steps required before and during surgery to support accurate, guided, full arch treatment planning. We also, what we're going to be doing tonight is comparing same day and next day provisionalization. We're going to be talking about 4 different aspects to be able to do that, but we're going to talk about all those options and evaluate the clinical factors that influence in selection of each of those protocols. And then lastly, we're going to explain the advantages of utilizing a shared software platform between the clinic and the dental laboratory to enhance calibration, streamlining workflows, and improvement of patient outcomes. So these are our learning objectives for this evening. And there's also a variety of different resources that we will be going through. So these are some of the resources documented. And for myself, to begin, dental technology is in my blood. I'm here tonight to share my 22 years of full arch prosthetic experience. The person all the way on the left is my dad, my mentor, my teacher. So he's a Navy trained dental technician for many, many, many years. So that's my dad. The next picture from left to right, that's my Uncle Mike, who owns a dental laboratory that's about 5 miles from my house. And I'm coming to you guys from a little town called Frankfort, which is about 45 minutes south of Chicago. The picture in the middle is that's my brother. That's my brother, Steve, who also owns a laboratory, an ortho lab, which is just outside the Detroit area. I have a cool picture of my son grinding on a denture, working in the laboratory. And then there's myself. Every once in a while, you just got to sit at the bench and do the work. You got to keep everything nice and hot, working with different types of implants and prosthetics and so on. So whenever I get a chance, I always try to sit at the bench and just keep on going with dental technology and the love of dentistry. Now, the picture in the middle that I just switched over to, very proud, and this is my shout out to Erin. Erin is my niece. This is my brother's daughter, and she is graduating. She is walking. She'll be getting her papers and so on, her graduation from dental school, which is at Midwestern in Phoenix. So she's going to be doing that in June. So believe it or not, we got all these dental techs in the family, and we're finally going to have a dentist. So I thought I'd share that with you all tonight. And then lastly, over here, this is kind of a cool picture of my dad. I mean, when you find pictures like this, you just got to show them, right? Kicking back in the lab. He's got his feet up on the desk, smoking a cig. Yep, they used to do that in the laboratory, and he's got his coffee and he's got his Navy manual in the upper right-hand corner. And believe it or not, I actually have that manual right here in my hand. So I have that right here. In his Air Force manual, I have that tool too. And then, believe it or not, on his desk, there's actually a Bunsen burner. Yes, did I say the word Bunsen burner? I sure did. But cool picture of my dad back in the 60s as a dental technician in the Navy. And for myself, I've grown up in a laboratory business my entire life. So really, yes, I have all this years of experience working with the analog and the digital processes that we're going to be talking about tonight in Full Arch. But it's also, I'm very grateful because I wouldn't be in this business if it wasn't for my dad. And that's just a cool picture of where I grew up in my old house. And he was in the basement making dentures and partials and crowns and things like that. And he was also a teacher for 38 years, teaching dental technology, hygiene, and assisting. So I thank my dad for getting me to where I am today. So for tonight, this is our agenda. We're going to discuss the 4 opportunities when we talk about provisionalization, for these full arch cases. When I talk about full arch review, we're going to split this. This is going to be a fun program between 2 of us. I'm going to go through a little bit of an introduction of full arch that we all should know, but some of you, it might be a really good learning experience to hear about the fundamentals of full arch. But really, what I'm going to do is I'm going to be talking about, in the first half, is going to be the analog process. And then Tremaine will get into the digital workflows, which will be awesome. And then we'll leave a little bit of time for some Q&A. So this is the agenda for this evening. Now, CBCT and iOS, right? Intraoral scanning. This is a software that we all work with, which is called RealGuide. And it's a virtual surgery planning. Now, This information is very detailed about this software called RealGuide. Now, what's interesting is that back in the day, CBCT imaging, right, which is a DICOM file, we can take that DICOM file and we could do diagnostics, we could do treatment planning, we could do implant positioning, we can utilize that CBCT as 3D data to understand bone density, anatomy, nerves, and sinus, right? So that's all the detailed information that we had at one time, and we didn't really have intraoral scanning opportunities to merge files like what we do today. It's interesting when I lecture and I talk about scanning and so on, and we talk about full arch. If you go back about 8 to 10 years ago, if there was a room of 30 doctors in a room, and I said, how many of you all have intraoral scanners? Raise your hands up high. I'll tell you right now, out of 30 doctors, I probably get maybe one or two. The room would be like crickets. And it might be a blue cam, a red cam for single units, multiple units, CERAC. And, that is really all that we had. But what's interesting today, it's a completely different time. And when I say a different time, what I'm saying is that intraoral scanners, if I ask that same room, here we are today, and I asked the 30 doctors, how many of you have intraoral scanners? It's interesting. I'm going to say almost all of you will raise your hands. So when we think about CBCT and we think about the ability of intraoral scanning, which is being able to design restorations and create surgical guides or 3D printing, these are all the cool things you could do with intraoral scanning, right? We know we can do that with an STL file. So CBCT is a DICOM file, and an iOS, that is an STL file. But, today we have the ability to merge these files together. And what we do is we either concentrate either on full arch or maybe guided surgery. But the idea is by merging these files, it gives you what we call a complete digital workflow. So that's really the premise of the discussion of this topic for tonight. Now, something that's very cool that I want to share with you, and this is that RealGuide software. Now, RealGuide software gives you the ability to do single units, multiple units, full arch cases, partial dentures, anything that you want to do. But when we take these DICOM files and these STL files, the CBCTs, the iOS, intraoral scan, and we merge these things together, working with the laboratory, and National Dentex works with RealGuide to go through a process of treatment planning a case for you to be able to decipher a direction. So, for example, if it's the placement of implants, if it's the placement of abutments, if it's the placement of understanding temporary cylinders when we're converting, and that's one way to convert a temporary prosthesis. If we want to go ahead and do that, nowadays we have the ability to do it through software, which is absolutely amazing. And then the beauty of the software is that it's over the cloud. So if you want to be able to be involved as a surgeon, as a dentist, as a denturist, as a dental technician with NDX, to be able to come together and be able to review the process, to be able to bring or create a wonderful temporary prosthesis, you have the ability to do that. And Tremaine's going to talk about the digital processes in just a little bit. But I wanted to share this with you because it's so detailed, it's so cool, because back in the day, we didn't have things like this, but we have it today, and it's simplified. And it also gives us the opportunity to be able to share these files, talk with the patient, show the patient what it is that we're trying to achieve. And it really does give us all wonderful experiences and outcomes with our practices. So I wanted to share this with you, and this software is called RealGuide. Now, why are you all here tonight? Well, you're here tonight to learn about full arch. You're here tonight to learn about temporization, to learn about all the different opportunities that are available. You're really here tonight because what you want to do, it's all about giving back patients smiles. And here we have a situation. It's unfortunate the teeth could not be saved, but we go through a process of placing implants, abutment prosthetics, temporary cylinders. We take a temporary prosthesis, for example, a denture, which is created by the technician, and we go through a process of adapting or creating holes and adapting and curing in with composites and acrylics and all kinds of different things, these temporary cylinders to this temporary prosthesis. And we have little screws that hold these temporaries in place. And this is all done either same day or potentially even the next day. And I know that Tremaine will talk about that in just a little bit. But the bottom line is it's all about giving back patient smiles. And this could be done the same day, or it could be potentially done the next day. So for example, here's another example. Here we have a wonderful patient that comes in. Unfortunately, they have a situation where the teeth could not be saved. And what we do is we go through a process, right? What we're going to do, unfortunately, we are going to remove the teeth. We're going to open the space to be able to eliminate some of the bone to create that space. We're going to place implants, abutments, and cylinders and screws, and we're going to go through all these processes to create this temporary prosthesis. And we're going to convert that either the same or deliver the next day. Sometimes we take impressions and we deliver that beautiful smile. This particular situation and the situation I showed you previously were cases that were done the same day, but working very close with the laboratory technician. We worked through a process of teamwork, and this is something that we've learned over the years. Now, I've been working with this process for over 22 years, and I know Tremaine's been working with the process the same time. And we've learned so many things that have really streamlined a process to create, I'm just going to say it, simplicity, but give us really nice outcomes and have an understanding before we actually do the case. Where back in the day, and sometimes even today, we still utilize analog processes where we take impressions and we take photographs and we create models and we create temporary dentures and we do all this work. Like this one was done the same way. And we go through a process of either guided surgery or non-guided, and we place the implants, go through the process and delivering these screw retain, only removable by you temporaries. And that patient goes home with a balanced occlusion. We talk about the soft diet. And from there, they go home with that wonderful smile. The picture on the left, how they came in before, and the picture on the right of how they went home that same day is absolutely amazing. It's astonishing of the things that we can do today. But there's many different ways and different directions to be able to do that. So when I talk about full arch rehabilitation, there are thoughts from patients, doctors, and staff. When I talk about patients' thoughts, we talk about creating new outlooks on life. This is what they're thinking. Ability to chew again. I have my smile back. Best investment. Being happy again. And I hear this one every time. I should have done this earlier. I hear that all the time. And then there's also doctors, staff thoughts. Well, we're talking about eliminating disease, improving quality of life, offering patient comfort, building relationships within the practice between the surgeon, the dentist, the laboratory, us as the manufacturer representatives, the parts and the pieces people, right? And what it does is that it creates what we call a personal gratification. You guys in our audience tonight do wonderful things for your patients every day. But when you work on patients and do cases like this, I'm telling you right now, it changes your perspective. It changes your thought process. It creates a personal gratification, and it creates confidence within yourself and your practice for your patients. So in a nutshell, that's really full arch rehabilitation. Now, let's talk about immediate loading. And what is immediate occlusal loading, right? Well, some of you may know this and some of you may not, but it's interesting to let you know that immediate occlusal loading is a process. It's when implants are placed with primary stability, typically 35 Newton centimeters of surgical insertion torque or higher. That's very common. But primary stability is very important to do cases like this, and fully functional occlusion, which is balanced. Now, immediate occlusal loading requires multiple implants rigidly splinted by a fixed prosthesis. Basically, we're placing 4 or more implants. Very traditional, 5 on the mandible, 6 on the maxilla, very predictable. But what we're doing is we're taking a temporary prosthesis, we're luting these cylinders together as one way, and then this beautiful full prosthesis is turned into a mini temporary prosthesis, which is screwed into place and delivered, and the patient goes home that day or maybe next day with a beautiful smile, as you can see to the picture on the right. So this is really, in a nutshell, what is immediate occlusal loading, right? And it's all these wonderful things that we're talking about tonight. Now, this is a really cool picture that talks about before treatment and after treatment, okay? So for example, before treatment, we have a denture on the opposing, and the patient is partially dentulous on the mandible. Now, just so you guys know, I lecture, and I've lectured thousands in front of thousands of programs over the years, and thousands of doctors and audiences and so on. And I could be lecturing all over the world, and I hear the same thing. And you know what I hear? We don't have these patients, and they can't afford it. Well, I'm telling you, the patients are out there. They are out there, and they find ways to be able to afford it. There are even times where we even streamline a case where maybe we'll place 2 implants and do an overdenture. Then we'll place 2 more implants, and then we'll do a fixed restoration. So there's always a way to be able to do something with your patient. It's all about the discussion of what it is that you want to do and what it is that you want to achieve for your patient. But I will tell you, the patient that accepts the treatment the most is a patient just like this, the before treatment. They have a denture on the opposing, and then on the mandible, they typically have a partial denture supported by 4, 5, or 6 remaining teeth. And these teeth are like snaggle teeth, unfortunately. I don't know how to say any other word, but yes, like snaggle teeth. These are patients that they're worn out with traditional dentistry, like piecemealing the case. They have a high caries rate, which they do, and they don't want to go without their teeth. So when you're treatment planning or thinking about a patient, that's the guy that accepts the treatment the most. So now the pictures below. What we've basically done is that we've chosen an implant that gives you high primary stability, really good bone implant contact, and can achieve a surgical insertion torque of at least 35 Newton centimeters or higher on each of the implants. So the process would be placing an implant, placing an abutment, or what we call a multi-unit abutment. They come in straight, and they come in 15 degree, 17 degree, 30 degree, all these different types of angled access to be able to get the access where you want it to be, which is always lingual. The bottom picture on the left shows the access holes for you as doctors to remove the prosthesis and restore the restoration. And you notice how everything is tucked in slightly lingual. So we have abutments that takes care of that, and that's involved in the treatment planning process to be able to know what it is that we need for the case. Now, once that the multi-unit abutments are on, there is, for example, this is one way to do this. There is a temporary cylinder, and then that temporary cylinder is held in with a small little prosthetic screw. And as you can see the picture on the left, you can see that the holes were bigger. You can see a little discoloration of a different color, like an acrylic or composite. So you have to make these bigger holes to be able to put these temporary cylinders on. But we bond them together with composites and resins or acrylics. And eventually we cut down, and we have where we can establish a bite, and we polish and we finish. And once that the prosthesis is in, and you can see the picture on the right-hand side in the middle, where we balance the occlusion the best that we can, you'll notice that the temporary, this is a temporary, and you'll notice that the cantilever of the temporary is also only 5 to 7 millimeters distal to the 2 temporary cylinders, which is very common. So when these patients go home, they're not going home. Well, it depends on where the implants are placed, but really they're going home in a first premolar occlusion, because typically these implants are placed like forward to the frame and or forward to the sinus. So you're looking at more like in a lateral, like a central, like a lateral canine first premolar position. So again, they're a little bit more forward, right? And then in this case here, what we're doing is we're not giving them first molar occlusion, because we know a lot of the biting forces are being applied in the posterior, right? But this is only a temporary, and we don't want to cause any problems on integration of the implants, osseointegration, and we don't want to create any fractures or any type of potential issues that can break or that prosthesis in itself. We don't want to have any maintenance issues. So basically what you see in that temporary is very common on how our patients go home in that first premolar occlusion. But keep in mind that in the final restoration, according to AP spread, they will go home with their final restoration in a first molar occlusion. But this is a very traditional case to be able to share with you. Now, when we talk about bone quality, bone volume, and bone width, this is very common. Type 1, type 2, type 3, type 4. We're really not placing implants in type 4 bone. But nowadays, with implant designs, we actually can and achieve high primary stability, believe it or not. But it is common type 1, type 2, and type 3. Typically, your minimal length of implant is about 10 millimeters, and your minimal width with good quality bone around that implant, you're typically looking at about a 4 millimeter. But I will tell you that there are smaller diameter implants that now have these thread integrities that can really give you that high ability of insertion torque, and it all depends on the thread integrity of those implants. So I will tell you, yes, The standard of the industry is kind of the 4 millimeter implant diameter, but sometimes, depending on the system, you can actually go with a little bit of a smaller implant. When we talk about vertical space, how much vertical space do you need for a prosthesis like this? For a hybrid, you need at least 15 to 18 millimeters of space. 15 to 18. 15 is the average. And I have two lines on here. You can see the two yellow lines. So I'm looking from the implant to the incisal edge of the restoration. So what that encourages, that talks about the abutment. It talks about the bar that would be utilized or the prosthesis. It talks about a little bit of space underneath the prosthesis for cleansability. We talk about acrylic and teeth. So if this is a traditional hybrid, which is a CAD/CAM mill bar with acrylic and denture teeth, which is still about 50, 60% of our business, that restoration needs 15, 18 millimeters of overall vertical space. And it's important to understand that, because if you minimize that space, especially for a temporary, I'll tell you in my experiences, what we see screw loosening issues. We see potential of tooth fracture, right? So we have to have good, adequate space. And 15 to 18 millimeters is the magic number. And again, that's from the implant to the incisal edge of the restoration. That's anterior, that's posterior, that's upper, that's lower. AP spread, very, very important. Anterior, posterior spread. So, for example, within RealGuide, or if you're doing this as an analog process, we can go through the situation of actually understanding the placement of the placement of those implants. So, for example, in the most anterior implant, we have 1, 2, 3, 4, 5 implants. We make a horizontal line across the most anterior, horizontal line across the two most posterior implants. You can see that. Basically, what we do is we measure in between from the two lines, right? The two horizontal lines, we measure in between in millimeters, and we multiply that by what? 1.5. And that calculates the cantilever for the final restoration. So for the temporary, like I said, they're basically going home 5 to 7 millimeters to the two most distal implants, which is typically, even a case like this, would be like in premolar. But in the final restoration, depending on how that the implants are placed, it is calculated. And this goes all the way back to Charlie English back in 1997. But we take this information as dental technicians, and this is how we design your case, either it be through the RealGuide software or traditional, just working analog on models. But understanding AP spread is very, very important. Now, understanding smile line, taking lots of photographs. For example, full face, lip at rest, full smile, left lateral at rest and full smile, right lateral at rest and full smile. Take as many photographs as you can. Nowadays, we do things a lot digitally, but if we're still in an analog process, which I'm talking about right now, we still take lots of photographs. And it's really important to understand those photographs for the technician to create this beautiful temporary prosthesis. Now, when you're working on a maxillary case, these photographs are even more important because it helps us to understand the junction between the natural pink and artificial pink. So it's affected by lip mobility, smile line. That's why the photographs are important, the amount of bone and size of teeth. So what we're saying is this: it's very important that when a patient smiles, that the border of the temporary prosthesis is not visible. So take a picture, so think about this. On the right-hand side, on the maxillary case, maybe we have 4, 5, or 6 implants. We have abutments, we have cylinders, we have screws, we have all of these cool things. And that's a temporary prosthesis, which is inserted. But think about this. If I have this restoration and you have a situation where we had a full prosthesis and then we cut it all back, right, to remove the flange and the palate, and we do all that to make it to a temporary restoration, you can imagine when the patient smiles, and if you saw the line demarcation between the pink and the tissue, that's a bad day. And that's because we didn't understand either the space or the smile line, and we just didn't understand. But these are things that are important to understand. On the picture on the left, that was a situation where the patient smiled and you saw that line demarcation. Maybe they didn't remove enough space. Who knows the situation? But, do we go home in that situation? Of course not. What the lab technician did was they created a flange. So chair side, because remember, the lab technician is the key to the success of the case when it comes down to a conversion process. So what's going to happen is that when the technician is there with the surgeon, with the doctor, with you, all working together to do the conversion to give that patient a wonderful smile of that temporary prosthesis the same day. So in this particular case, what they did is they added a flange. Now, I'm going to tell you right now, flanges are not good for hybrids, right? Remember, this is a screwed down prosthesis. Now we got to talk about cleansability and how the patient's going to maintain and hygiene and take care of it. But in this particular case, they did go home with that flange because of the smile line. And then what they'll do is they'll test drive the case, they'll follow up with the patient, make sure they're taking care of it. And then decisions will be made if we're going to continue with a hybrid, which we may not, because these are hybrids and you can't have a flange with hybrids. Or what we might end up doing is maybe we'll do a fixed detachable or maybe even a removable, but probably a fixed detachable. Okay. So understanding smile line, photographs, transitional line, very, very important. So keep in mind, immediate full arch is not for everyone, right? I'd love to say that everyone's going to accept this treatment, but not everybody does. It has a lot to do with patient selection, determining if the patient is a candidate for the process. You also have a personal responsibility to talk about good, better, and best, right? We're talking about a denture, an overdenture removable prosthesis, and of course, the best treatment option, which could be fixed. It's very important to understand follow-up with your patient, talking about home care and patient trust, right? These are patients that have situations that unfortunately they're losing their teeth. And here we are trusting these patients with these hybrids. That's the thing I love about provisionalization. The thing I love about it is that you're test driving the case. It's not like we're placing implants, waiting, coming back, making a restoration, delivering a restoration, and then determining if the patient can take care of it or not. That's not the time that you want to be able to do that. You want to be able to do it in a temporary phase. So that way it gives you the ability to trust that patient and understand how they're doing with the maintenance. And if they're not taking care of it, I'm going to tell you guys right now, if they don't take care of these prosthetics, I'm going to tell you these implants will fail. It's not like they might fail or maybe fail, they will fail. So you got to be really, really cautious with that. So the bottom line is this: we make our temporaries. We talk about patient home care. We talk about proxy brushes, superfloss, water picks, maintaining, taking care of it. And we build the trust to be able to finalize that restoration of what we give them when the case is done. We also talk about prosthetic expectations and maintenance and so on. That's for another night. But the bottom line is, guys, is that immediate full arch, immediate placement of implants, creating a temporary, delivering same day, next day, analog, digital. The bottom line is it works. And the success rates are very, very high. So a couple more things to share with you, and then I'm going to stop my screen and put it over to Tremaine shortly. But, what records are needed to start your case? So let's think about this: analog versus digital. I'm going to talk about the analog process, and I'm going to do this very quickly. So when I talk about the analog process, we're talking about what does the lab need to begin the case? Well, I've already talked about photographs, many, many photographs, and taking impressions. This is the analog process, kind of like the old way, but we still do it today, believe it or not. But we take impressions, the laboratory creates a model. The model will then be articulated. What we do is in the laboratory, we measure from the incisal edge down 15 millimeters as an example. And what we do is we eliminate the teeth and we create you an immediate denture. So the basis of the beginning process within an analog process is creating you an immediate denture. And that's what we do. Now, there's also another process where you can traditionally place the implants where we're utilizing a surgical guide, but this surgical guide is actually utilized when we're freehand placing the implants. This is not a guided approach, which is what Tremaine's going to talk about in just a little bit. But what we're doing is that we take that denture, we duplicate that denture, we hollow out the intaglio of the prosthesis, and that helps us for implant placement. It helps us for, even before implant placement, bone reduction to get the 15 millimeters. And not only that, it also helps us for angle correction of our abutments to make sure that the access holes are coming lingually. So an analog process without a digital process, traditionally kind of old school, is the process of creating models, utilizing photographs, impressions, creating a temporary prosthesis, and creating a surgical guide, which is a duplicate clear stent of the temporary prosthesis that we're going to utilize for the conversion. Now, There's many different ways to make a denture. We can print and characterize. We can also go the traditional process of waxing and investing and boiling out and packing. And there's my son. He was working in the laboratory creating a denture. But however it is, the denture has to be made. The denture is what we're going to use for the conversion process. Now, there's 4 techniques, and I'm going to run through 2 of the techniques, which is a traditional process and what we call a smart denture conversion. When I talk about a traditional chairside pickup, this is the process of what we do. Now, the patient has accepted the treatment. The implants are in. The abutments, the multi-units are on. The angle correction is done. Everything is ready to go. This might be sutured. This may not be sutured. But the first thing that we do is we take the temporary prosthesis, we squirt in some impression material, we seat it in the mouth, we take the impression material, the bite registration, we take it out of the mouth. The picture on the bottom left, we take a burr. In the laboratory, we take a burr and we drill all the way through the prosthesis. You can see that where we're enlarging the holes on the bottom middle picture. Then what I do is I make the holes even bigger. So when we put the prosthesis back in the mouth, I look down and I see the access to be able to get to those multi-unit abutments. The next step that we do, we put on temporary cylinders and we cut those cylinders so we understand vertical height, because we want the patient in occlusion when we eventually connect these temporary cylinders with composite or acrylic. So in this case here, we've cut down the cylinders where we have our bite. What we're going to do is we're going to use rubber dam on the bottom left-hand picture. Rubber dam protects the tissues. What we do is we take some Teflon tape and we pack that into the cylinder and we seat the prosthesis. It's a whole process, but working with the lab, working with the doctor, working with the surgeon, we're all together in one room. We're injecting in these composites in the mouth. Picture this is all done in the mouth, and we get the bite. We establish the bite. We go through a process of letting the material set. We unscrew everything. We take it out and we begin polishing and finishing. This is a traditional denture conversion. This is where the laboratory gets involved. They polish and finish the temporary restoration. And when they send it home, all voids are filled in underneath the prosthesis. It's nice and rounded. There's no sharp edges on the prosthesis. The occlusal surface is also polished and finished. It looks like a beautiful temporary restoration that will be inserted. It will be dialed in regards to the occlusion, tap, tap, grind, grind. And then we're going to go ahead and put in our little prosthetic screws. We're going to x-ray, we're going to torque, we're going to fill in these little access holes, the bottom middle picture. We're going to fill in those access holes with a little bit of impression material, and we're going to send the patient home. Okay. So this is a traditional drilling out the holes and utilizing temporary cylinders. Now, there's another process which is called smart denture conversions. I'm not sure if you guys have seen this, but I'm going to tell you it is absolutely awesome. And what it does, it talks about large holes, like the pictures on the left, right, with traditional, but making smaller hole technology. So we understand that been there, done that. Bigger the hole, higher percentage of the resin prosthetic failure, especially when utilizing composites. I get that. So bigger the hole, the weaker the restoration. So this is something that we need to be we have to understand, but we don't want to have happen. And what other concerns that you might have when we're converting a prosthesis, right? Establishing the vertical, understanding occlusion, understanding the midline. And these pictures on the right, these are all wonderful prosthetics that are inserted the same or next day, but you'll notice that sometimes the midline's not always perfect. Maybe the occlusion's not always perfect. We try to make it perfect, but it's a temporary, and that's what the patient will go home with. But the bottom line is that we will obviously change these things for the final restoration. So is there a way for clinicians, technicians, and denturists to save time, create smaller access holes, and deliver a stronger temporary restoration with a more perfect or ideal bite? Is there a way to be able to do that? Well, this gentleman here, so that's me on the left. This gentleman on the right, that's Dr. Brandon Coford, who is a genius, a prosthodontist who created a way to make smaller hole technology to increase the strength of a prosthesis, but be able to convert a restoration within 30 minutes. And I actually did it at this program in less than 20 minutes. But Dr. Brandon Coford created what's called smart denture conversions. It allows us to convert a prosthesis within 30 minutes. It makes smaller holes, which is easy and predictable. And what it also does is that it's a closed tray pickup technique where we're actually picking up tie bases. And by doing a closed tray pickup technique where we're not drilling out all these holes, this gives you the ability to get the bite just right. So the midline is lined up, the occlusion is dialed in. It is so cool. It enables clinicians and technicians to work better. It improves productivity and profitability when we do these types of cases. So lastly, to let you know, this is what smart denture conversion is. You place your implant, you have your multi-unit abutment, but this is the system. It is a tie base. It's a tie base that fits on top of the multi-unit. And what we do is we utilize what's called a separable fastener. It's a small little screw. As you see in the picture with the arrows, it's actually a screw thread with a little shaft on it. And then there's a little plastic piece. It's actually PEEK, polyether ether ketone. That little plastic piece actually press fits on top of that little screw. And that is threaded in with a torque driver, very specific. And that's all held into place. And when you go through a process of the conversion, you're not drilling out holes, you're just drilling out the bottom of the prosthesis. It's almost like picking up an overdenture attachment. You don't go through all the way through the prosthesis, but you actually hollow out like a shell underneath the prosthesis that fits over the tie base. And then you connect that tie base with composites or acrylics, and you actually pick it up. It's really a cool technique, and it's called smart denture conversions. And then lastly, what they do is they utilize what's called a pilot drill, which actually goes through the prosthesis and creates this small little hole, which is the picture in the middle. Then we utilize an access drill from the occlusal. And then we utilize a clean out drill, which is on the bottom left, to remove that little separable fastener. So again, versus drilling out these big holes, we make these smaller holes. You remove these little separable fasteners, and then you have the ability to seat the prosthesis, put the final little temporary screw in place, and then go through all the processes like what I talked about before, adjusting occlusion, torquing in the screws, x-ray torque, and then applying some impression material in the access holes, tap, tap, grind, balancing the bite and sending the patient home, which is really, really, really cool. So there's a couple of different ways to be able to create your temporaries. We can do a traditional where we make the holes, or we can go through a process of doing what's called smart denture conversion. So that's the first two parts of the program. I'm going to go ahead. Tremaine, I'm going to stop my screen. I'm going to stop talking. I'm going to go ahead. Let me stop this. Bear with me just for a second. I'm going to put it back to you. And that way you can switch over your screen and then you are ready to rock and roll. Sorry, I went, how did I do? I went over by just a couple of minutes. So I'm sorry about that, Tremaine. But I hope all good information.
Very good information. Yeah, thank you very much, Wayne. And both of those are great methods. I've done both of them, and I agree with Wayne. The smart denture conversion, it doesn't seem as different until you actually do it. But being able to just set the denture on, not worry about how the screws are lining up, take the whole thing off and drill your holes very precisely through there. The finish of the restoration is so much nicer. And as Wayne said, you can then get that nice occlusion in the mouth that you designed with the immediate denture. So it really does make a big difference. Both of those allow you to get a nice same-day provisional. So let's talk about a couple of digital workflows. So those are two analog workflows that you can use today in your practice if you like. And then we're going to talk about two different digital workflows. So I have a couple of, as Wayne did, I have a couple of foundational slides. I'll go kind of fast through this. But with digital records, you guys know that the way a digital file is built, it's a bunch of 2D pictures where the software creates a 3D image by stitching common areas and then builds a point cloud, oftentimes and then the points are grouped into triangles. All those triangles, this is the kind of the important thing, is that there's an imaginary center point that each point is measured in XYZ distance. So let's say you're scanning a patient, you scan the upper arch. You know, you watch the the 3D file developed. And you're like, great, okay, I got my upper. So you turn around and scan your lower, and you get another 3D object. But what's really important on All on X is the way that the bite works. So when you start scanning the bite, the software looks at the upper and the lower arch and finds common points. And you'll notice that they're kind of sitting there in space, and then all of a sudden they snap together. And what's happened at that point is that the two origin points are now the same. So even though you can work with the two files separately, they're essentially intrinsically related to each other. And one of the things we need to think about when we're doing digital all on X is that we're going to be trying to align lots of different files. And as you know, when we go through this process, the patient's mouth changes quite a bit from their preoperative situation to where they finish up. So one of the things you need to be thinking about is, I'm going to have to line up all these files, or my lab is. What files do I need to create to make this happen? And we're going to talk about kind of a typical case, but keep in mind that there are going to be unusual situations. Maybe the patient's edentulous. Those can be a little more challenging, especially on the mandible. So make sure that part of planning a digital full arch case is having a specific plan for, how am I going to line all these files up to get an accurate relationship? Oh, one other thing about this is, in the olden days, if we had a bad impression, things wouldn't fit. That would be the first indicator. Well, with digital workflows, they pretty much always fit. Where we run into problems is with our occlusion and with our tooth position in extreme examples. So what we want to do is, when we're talking about file alignment and stuff, we want to make sure that we have a good plan, so that way you get the beautiful occlusion and tooth position that you planned. So we also have some cool ways that we can simulate and show our patients what we can do. This is an example of exocad Smile Creator. And I realize that this is kind of an odd looking case, but I picked it on purpose. And I anonymized it, so you can see that the person smiles a little bit asymmetric, but if you saw her whole face is a little bit asymmetric. So one of the challenges with this case was trying to pick a tooth arrangement that looked nice for her, that made her face look as good as we could. And so this gives her and the clinician and the technician opportunity to look at it. exocad Smile Creator, I think, is a great tool. It allows a 3D design to be aligned to a 2D view, but it's only valid from one view. I would say today, and especially as we're going forward, more and more 3D facial scanning is going to be important, because that allows you to turn the view any way you want. You can look at the person, like look underneath and see, how are the teeth relating to the lip. You can rotate side to side. How's the profile look? And that when you take several facial scans, you can actually see, kind of watch the patient smile, go relax lip, then turn on another one, smile, and then Duchenne smile. One other thing to keep in mind is, this is really another, I'm going to talk about a couple of fast moving areas, but this is a very fast moving area. I can think of one vendor in particular that will take basically this and create a AI, like a deep fake, basically, that allows you to see the patient go smile, nod their head. It's pretty cool. So you want to be thinking about your patient's requirements and making sure that you can, reassure them that they're going to get a result that they want. The other thing I would say is, when you're thinking about these tools, you need to pay a lot of attention to, what does the tool show and what do we actually get? Again, one of the things I like about 3D facial scanning is that when you do a case with a facial scan, it looks exactly the same when you deliver it. It's so cool. It's the best thing ever. I'm a huge fan, if you can't tell. But make sure that as you're presenting different cases, save the picture, and just for your own records, take a picture at the end. So that way you're validating, yes, we're getting the good result that we want. So the two workflows I'm going to talk about are a fully guided workflow where we can deliver a same-day provisional, and then we're going to talk about a digital workflow like photogrammetry that allows a next-day provisional. So when you're doing guided surgery with the same-day provisional, we're going to need 4 sets of records: a CBCT scan, the surface data. I kind of coined that term. Who knows if it'll catch on, but That way we can kind of group either an iOS scan or a physical impression. I like iOS better, but if you need to do physical impression, that's fine. We want to make sure with these cases, and Wayne mentioned this, that when you're doing the bite registration, it's not so much where the patient is now, it's where they need to be. And we'll talk about that a little bit more. And then, as Wayne mentioned, a series of photos that show us what's going on, especially that high lip line, because the transition line is just as critical with digital as it is with analog. One thing you want to keep in mind with guided, a CBCT scan in guided is not just for visualization as we often use it, but it's actually, if you want to think about it this way, it's an iOS for bone. So we're going to define the bone very carefully, and that will become a, so to speak, a model, and we'll build sometimes even metal components on there that don't give very much. So you want to take a really nice CBCT scan. A couple things you can do to avoid this is called scatter. You don't want to see this, is you can take an open bite. You want the teeth uncoupled. That will cut down on the scatter. You also want to set your voxel size at 0.3 or less, so we get a little bit better resolution. And even in some circumstances where you know there are a lot of restorations, you can use Monosil 2, which is like a clear bite-looking material, and make like almost like a sports guard out of it to suppress some of the radiation returns. One of the things we can remember is that, like Wayne told us, we need a certain amount of restorative space, whether we're doing an acrylic hybrid or zirconia or whatever kind of restoration we're doing. And it's from the plane of occlusion to the implants. And a lot of times we're thinking about alveoplasty, which is very common with FP3s. But the other thing to keep in mind is if the person has lost vertical like this poor patient, and I restore some, not only does it make the facial proportions more pleasing, but I just picked up 3 or 4 millimeters of restorative space with no alveoplasty. So when you're evaluating the patient and finding that VDO, it can really help, helps the whole case at the same time, I guess. If you've never seen this before, this thing is the coolest thing ever. It's called a VDO gauge. And what it does is this side of the gauge, you measure from the corner of the eye to the corner of the mouth at VDR, basically. Then you flip it over, put this under the nose like this, and then this under the chin. If the chin area holds this off the nose, the bite's over opened. And if there's a gap, the bite is over closed. In this particular case, the patient was a little bit over closed, and you can see that the clinician's using a leaf gauge to get the correct VDO. The other thing that's cool about this is popsicle sticks, VDO, it all works great, but you can't really put the popsicle stick in the chart unless you tattoo the person's face, and they may consider that a less than acceptable outcome. With this, it gives you a number. See, this person's at 68, so you can put 68 in the chart, whip out your VDO gauge every time, and validate, is my provisional at the right vertical? Is my prototype at the right vertical? Is my definitive at the right vertical? Makes it much easier to carry through the whole process. So if you like VDO, VDR, that's a great technique. I'm not wanting to rain on that parade. But if you haven't found a really repeatable way to establish VDO in your practice, I would recommend this. This will really help you. Once you've gotten all your records, you'll submit them digitally within Sequence, which is kind of the process we're talking about tonight. There's an online prescription, and you can put all your records in a zip file. If you're doing physical impressions, feel free to print out a mailing label. So then this is where RealGuide comes in that Wayne was talking about. In RealGuide, we'll define all the different structures in the CT scan, and then we'll line up the model scan or the iOS to the CBCT, digitally extract the teeth, design the prosthetic, and then position the implants based on ideal prosthetic position. You know, a lot of people talk about prosthetically driven treatment, but the prosthetics designed first in this situation before any alveoplasty is planned or implant positions. So this is a great way to do a truly prosthetically driven workflow. So then you get a kit that has a foundation guide. I'm going to skip to the next slide because this shows it better. You get your metal bone foundation guide. This is what I mean about the accuracy of the CBCT scan. This is printed partial metal. It does not have very much give in it. So your CBCT scan needs to be very accurate so this seats easily. There's a little monostrut. This is an index piece to make sure that we get the foundation guide in the right spot, surgical guide, and then the provisional that's pre-drilled already flat. You also get some reports that show which instruments to use, so that way you can get the correct depth and the implants come out exactly where you planned them. So we'll kind of talk about how you do the process. Again, I'll try to go through this kind of quickly. So there are two kinds of monostruts. And the monostrut, I realize that's kind of a confusing term, but if you look at this foundation guide, actually, let me go back here so you can see this better. Okay, see these little straps here in the posterior? These are the most important part. When you're doing a case surgically, these little areas right here have to sit right on the bone. That's really, really important because that sets the vertical index for the posterior aspect of the whole case. Not only the implants, but also the prosthetic. But then you got to think, oh, well, this slides over the bone here. So how do I know how to pivot it, how to rotate it into the correct position? And that's where the monostrut comes in. In the case of a two-supported, we'll use selective extractions and it'll index on the remaining teeth. So that way we seat here and then we swing this to place. And that way we know that the foundation guide is exactly where we want it. The reason that's so important is because everything is indexed to the foundation guide. So if you get the foundation guide right, the alveoplasty will be right, the implant placement will be right, and the prosthetic position will be correct. For those patients that either don't have any teeth or where you'd sooner just complete your extractions, you can use a bone-supported monostrut where the little arms here seat on the ridge after extractions, and then that indexes the bone foundation guide. That's kind of an intro. Now we're going to kind of go through the process. So the first step is to do the majority of the extractions. There are some people who make guides that seat with all the teeth in place, but what you'll notice about those kind of guides is that there's a huge gap between the bone and the guide, and the problem is it can be mispositioned a little bit and it's hard for you to tell. You'll see how the adaptation on these guides is quite a bit closer than that. So in this particular case, it's designed to index on 7 and 10. So the rest of the teeth are extracted carefully. We want to save we want to keep the bone as intact as possible because the planning was based on atraumatic extractions. You'll find in general that your tissue reflection for a guided case is a little bit larger than it would be for a freehand. And then here we see the bone or the two supported monostrut. So you see how the little arms, see how back there they're sitting on the bone, and then the anterior, the monostrut seats on the teeth right there. When you're doing this in the real world, it's best to try in the bone foundation guide by itself, the monostrut by itself, make sure they seat readily, and then put them together. You can do it together from the beginning if you want, but it's just such a big thing, it's hard to visualize. I find the others a little more predictable. So with a bone-supported monostrut, one of the things that's cool is it has occlusion. So if you need to, you can kind of close a patient's bite to give you an additional index. But if the index between the arms and the index between the occlusion are a little bit different, the arms are the correct one to follow. So you've got the case indexed, you hold it down firmly, and then you drill right through the foundation guide with your 1.5 by 20 guided drill, and then place the pins right in there. Once you get your pins in place, your monostrut's done, you pull your little, we call strut pins here, and then you want to visualize, there's a little piece in the kit that shows the amount of bone and teeth, if there are teeth involved, that need to be removed. And you kind of look at it as a double check. Yes, I got everything in the right position. See how we got a nice fit there. So extract the remaining teeth through the alveoplasty. The top of the foundation guide isn't in a random position. What you want to do is level the bone with that. So it's your guide for your alveoplasty. The other thing is see how the foundation guide kind of fits to the bone. That gives you an additional index. So that way you can tell, hey, I got this thing in the right spot. It kind of has a home when you see it in the mouth. Once you get your alveoplasty done, you'll put your surgical guide in and you'll place your implants through the guide. Usually you'll be using a medium or soft bone protocol, as you know. And there's little blue lines on the guide. These are really important. You want to index the implants to those blue lines. The more accurately you index that, the easier your prosthetic conversion will go. Place your MUAs. As you know, when the MUAs are positioned well, generally the screw axes will be similar to each other. And then you can set the pre-drilled provisional over the temp cylinders once you get the MUAs and temp cylinders in, like Wayne was showing. One thing to keep in mind is this is not indexed to the bite. I mean, it has a correct bite, but it's indexed to the foundation guide. So that way your planned tooth positions are carried to the mouth in the same way your planned implant positions are by indexing them to the foundation guide. In this case, the case needed a little bit of relief right here. So then we'll pick up the material with a composite or acrylic resin. There's little vent holes in the buckle, so you inject from the buckle until you filled right at the bottom of the temp cylinder, and then I like to flip over to the occlusion and fill the rest of the way. There's these little blockout straws that help keep resin from getting in the screw holes. They don't seem that cool until you've done one, and then you're like, this is the best thing ever. I can just put my resin wherever I need to, and the screw hole is right there for me.
Yeah. Hey, Tremaine.
Yes, sir.
Hey, so, but the coolest thing ever within Sequence is that this is all, is that right? It's digitally processed where the occlusion, the posterior restoration occlusion, I mean, the facial aesthetics, I mean, this is all like digitally planned. Is that correct? The hole's already created. Everything's like in advance, not like I was showing you before where you have to drill it all out manually. Is that right?
That's right. This is what it looks like when you get it. It's flat on the bottom, cut out in the palatal side, and it already has the holes in it. 100%. Yeah, it saves you a lot of time.
Yes.
Thank you, Wayne. Yeah. So then once you picked it up, you go ahead and detach your strut pins and undo your prosthetic screws, take out your little block out. And then if you have a technician working, you can kind of divide and conquer. So on the clinical side, you'll want to place, I always recommend placing the MUA cover caps first, then remove the bone foundation guide. Then you'll need to, usually with this process, you'll have kind of a sharp corner at the edge of the bone. You'll want to round that, do any grafting you need to, put in membrane if you've done grafting, and then suture. When you're suturing, you want to suture a little bit loose with these cases because the tissue is, as you know, very mobile and it wants to fold up over the MUAs, which isn't the most awesome for you. You will be protecting it with the prosthetic. A lot of people talk about it as a plastic bandage. So you do yourself a favor and keep them a little bit loose. Meantime, your technician can do the finishing. And like Wayne said, it's not that difficult. You fill in any voids. You can put your little blockout screws back in. And then there's the arms, cut the arms, blend it, polish it. That's it. So usually our technicians kind of are racing with the dentist to see who can get done first. And it's pretty hard to beat somebody when all you got to do is these little steps. But once the prosthetic's done, you'll remove the MUA cover caps. As I said, the tissue can lap over, so sometimes you need to use an instrument to kind of walk the tissue back a little bit, seat the prosthetic, do your occlusal equilibration. Most people's TMJ is a little bit swollen and their bite may not be right where it needs to be. So a lot of times what you'll do is gross equilibration on the day of surgery and bring them back 24 to 48 hours once they've healed up a little bit so you can get a better bite for them. And as Wayne said, fill the holes with light body impression material. It doesn't get goopy. It's easy to take out. If you've been using cotton pellets, this one tip was worth the price of admission right here. Your life will be way better. So that's the guided same day. The other digital process is entirely digital workflows and next day delivery. Now, next day delivery, you may think, well, that stinks. I don't want to do that. But there are a couple advantages to this workflow. One is that there's no conversion, no acrylic work, no blockout screws, no nothing. you get a finished prosthetic that kind of looks like a final, except it's made out of a printed material, and you screw it in. That's it. You usually do need to anesthetize the patient locally because they're going to be a little bit sore. So you kind of want to plan on that. And again, the tissue can be a little bit, it can still be a little bit, it can still lap over the MUAs. So it's more challenging than delivering a definitive prosthetic, but there's no acrylic work whatsoever. So the different thing about these cases is that you can do it guided or freehand. If you're doing a freehand case, these are all the records you need. You can see kind of similar to what we were doing before. These restorations use a direct to MUA workflow. Most everything we showed you today has a temporary cylinder or tie base or something like that. But when you're using a digital record for the MUA position, we're finding that cross-arch accuracy of 20 microns or less. There are some systems that claim 5 microns. So it's weird. It took me a while to get my head around this too, because like Wayne, I started in the analog world where it's like the model is the supreme being of the whole process, and then we're always trying to fit things to the model. So with this, if you make a model, your model is less accurate than the digital file. So what we want to do is make the digital file, build the case model-less, and then use precise, predictable digital manufacturing processes so that we don't foul it up by seating it on a model, which is, I know it takes some getting used to. The other thing is, if you think about it, there's a potential for failure at this joint. Turns out there's no joints here, so there's no potential for failure. And look at this, where I would have normally had to put the metal, I can put all parent material. So it allows me to either make it slimmer or make it a little bit stronger or a little bit of both. So when you get a digital provisional, all you'll get in the box is this and the screws. So be thinking about that. Libraries and workflows. This is really important. I'm sure you guys have done regular implant cases and you got the case and you send it in and you're like, okay, I want whatever you want. And the lab calls you and says, oh, we can't do that. You're like, what? That's what I want. It's like, well, the scan body that you use doesn't allow the workflow that you want. The same thing happens with these digital workflows. The slide goes into it a little more detail, but I'm going to kind of skip over it. And what I'm going to say is that there are a lot of, with the direct to MUA workflow, the screw head shape becomes very important, and you want to make sure that it spreads the load evenly on the restoration. And so a lot of people who do this workflow have a preferred screw. So when you're working with these situations, make sure that you pick a scanning system that has a library affiliated with it that'll allow you to use the screw that you want. The other thing is, you know, we do these presentations, we want to make it, oh yeah, it's easy, everything's easy. Well, scanning in a bloody field, not that easy. I'm not going to lie to you. So when you're doing this, you want to make sure that you have a person, or you are the person who's very, very good at scanning. I would recommend doing some reference denture cases and different things like that, so that you know that you can take successful scans in a bloody field of tissue. Because like with this scan here, you have to scan everything that you see in this picture or the scan's no good. This is not a tooth only scan here. Remember, we talked about that you have to have good references so we can line all these files up. Because if we can't align this to this, everything else is different. So we'll wind up with a poor occlusion on the case. The other thing is that with our laboratories, and I think most laboratories that do this, you're going to need dedicated design time with a technician. So if you want to take a quick screenshot of this, this is how you schedule time. You have 4 options. You can, if you want to print it yourself, we can design it and you print it. We can design it, we make it, send it to you for the next day for a single arch or double arch. So when you're doing a digital workflow, there's really 2 parts to the digital workflow. The first part is 2 weeks ahead of time. You send the scans and photos of the person the way they are now. As Wayne was showing with the analog process, the lab will remove all the teeth digitally, and they'll do a design in correct occlusion with good tooth morphology and all that well ahead of time. You'll get what's called an exocad web viewer link where you can click on it and see the new design, see the original teeth. Sometimes you can even see the alignment to the photo in Smile Creator and make decisions about what you like. The goal on the day of surgery is not to scan bites or anything like that. We're going to do this tooth position precisely. The only thing we're going to do is we're going to take this perfect tooth design and we're going to adapt it to the new implants. That's what all these scans are for. So the first scan you got to do is you're going to put in what we call reference screws. Some people call them fiducial markers. For the maxilla, you usually put 2 in the palate. For the mandible, you can put 2 in the retromolar pad. And if you get one in the interior like this, it really helps. Now, why are we doing this, you wonder? The reason is because all of this is going to change during surgery. So what we're doing is when you scan this, your laboratory will use the teeth to line this scan up to the preoperative mandibular scan in this case, and then hand off the alignment to these. So that way it doesn't matter what happens here. These become the common point of reference. Now, can you move these during surgery? No, you cannot. Because if you do, then the alignment's no longer accurate. So these are really, really important. On the day of surgery, this is the first thing you'll do surgically is anesthetize locally, put these reference screws in, and take a full arch scan, a big scan like you would for denture. Now you do the surgery. Remove the teeth, flap, alveoplasty, implant placement, MUAs, suturing. Actually, don't suture yet. And then we need to get the accurate position of the multi-unit abutments. And I say multi-unit abutments rather than implants because these digital workflows always work to a multi-unit. None of them are designed to work direct to fixture. And if you haven't done a lot of full arch, trust me, you want to go direct to implant. Direct to fixtures are a pain. Direct to MUA. Direct to fixtures will be a frustration for you for the life of the restoration. Every time you take it out, you're going to be sad that you did it that way. So, and make the investment and do the MUAs. Photogrammetry is a system where you use digital records and multiple cameras, kind of like a GPS, to precisely measure these little dice things. You can see in this image, they're all green. That means that they've all been captured well. This is the most accurate system out there. Again, some systems are 5 microns from here to here. Most of our manufacturing systems have 50 micron tolerances. So this gives you the potential to do a perfect case. The equipment for this isn't free though, it turns out. And so if you have an iOS, a new generation iOS scanner and you want to use that and not purchase the photogrammetry equipment, there's a system called Simply iOS that uses kind of enhanced scan bodies that allows you to use your iOS to also capture very, very accurate implant position. There are a ton of systems on the market, and I'm not kidding. One comes out about every 2 months, it seems like right now. So again, work with your laboratory because some are more predictable in the lab than others, and some have more options for you with screws and different things like that. So the more you work with your laboratory, the more you guys will get the results that you want together. Now, a lot of these systems output MUA position only, so they're not aligned to anything, to the tissue, to the head, to anything. So we have to align. Remember, we talked about alignment's really important. So especially with photogrammetry, you have to be sure you pick the right kind of MUA scan caps, and then you're going to put those on the multi-unit abutments after suturing. Obviously, this is a healed case. And then take another scan of this. In this scan, you absolutely have to scan the reference screws. So what happens in the laboratory? So in the laboratory, you already have the nice design. So what your laboratory will do is your laboratory will use that preoperative scan with the reference screws and align it to the teeth from before surgery. Then they'll take that last scan we talked about, the tissue scan, with the reference screws and align that. So now we have the MUA healing caps. Then we'll align the photogrammetry or simply iOS data to that to get the implant positions precise. So basically what we've done, if you want to think about it that way, is we've dropped the new implant positions and tissue under the existing design. So now all we have to do from a design perspective is basically warp the intaglio surface so that it touches the tissue and it's hygienic, and then punch screw holes and seats for the MUAs, and then get the case printed. For those of you that haven't seen 3D printing before, this is kind of what a raw 3D print looks like. Everything is printed tooth color, and then it has to be cleaned very carefully and post-cured to get full strength. Then we apply the pink is applied as a composite material. The printed material, when you get these, it'll be the tooth color on the intaglio surface as well. And then check to make sure the screws seat through, that it seats on all the MUAs individually, and send it. Again, it won't come with a model. You'll get this in screws. But here's the cool part. Yes, you're doing it the next day, but when you deliver it, there's no adjusting. You screw it in, adjust the bite, that's it. One of the things that's important to think about with this is that practices that do this a lot tend to talk to the patients about a reveal appointment. They say, hey, you're going to go in, we're going to do all the work to your mouth that we need to do, surgery in other words, to get it ready for your new teeth. And then we'll design your new teeth. And tomorrow, when you're feeling good, you can come back and see your new teeth for the very first time. And this can be, for any of you that are really interested in building the full arch part of your practice, you need patient testimonials, you need happy people videos, and this is a great place to get them. So, because they're not so loopy. And as an added bonus, their jaw's feeling better, so you can oftentimes get a final equilibration at this time, so you don't have to bring them back again. As you know, really important, as Wayne said, to give them a schedule for when their sutures will have healed up, basically, and when they can start doing their water pick and their floss threader and keep these nice and clean. And so those are the two workflows that I'm talking about tonight.